want to start with a simple case. A patient 6-year-old came with a complaint of blurriness of vision for distance and nearby. This blurriness of vision he noticed since 10 days, and which is associated with headache and as well as the neck pain, and which is getting relief after the vomiting. That is a sign the patient can have an intracranial pressure rise, and which the parent noticed in an unhabitual environment when the parent was coming to the Bangalore. So first history was normal, and the first visit to our Narayana 2, the visual acuity was 6/24 for the right eye, and left eye was 6/12 part. And we are seeing here, the both the pupil was not reacting properly, and the fundus is revealing this edema for both the eyes. And we advise the patient for the neurologist opinion urgently. Then at the neurological study, it revealed that the patient was having a solid cystic lesion comprising a fourth ventricle, which is in the origin, and he underwent a midline sub-occipital craniotomy, which is a mass excision surgery. And after that, the patient came to us after 6 months of visits after the stable condition. Then after 6 months, we see the patient vision becomes a hand movement for the right eye, and left eye it became 6/60. And the patient developed right exotropic, can be due to the sensory thing, and the pupil is still fixed. And we are seeing the fundus. There is a diffuse atrophy for both eyes with the help of with presence of foveal reflex. And we have referred this patient for the vision therapy for 3 months. After 3 months, you can see here the vision improved from hand movement to 3/60 for the right eye, and left eye the vision improved to 6/48 from 6/60. So we are seeing here that patient was having the potential for increasing their vision. So we have referred for 3 months of vision therapy more. That was like weekly 5 days and 1 hour per day basis. But the vision was not improving after the therapy, after post 3 months of therapy. So vision became constant and 6/48. Then we thought to give a low vision trial for this patient. So after low vision trial, the vision becomes 6/12. So you can see here the previous vision when the patient came to us, it was hand movement for the right eye, and after therapy it becomes 6/48 for the dominant eye, and then after low vision of 4x monocular telescope, vision becomes 6/48 for distance, and near it became N6 with the help of the CCTV. So and the reading and writing skills significantly improved for the patient. So for the morning we are seeing how this CVA. The CVA is a brain-based blindness. Basically, I want to describe as this term, brain-based blindness, B3. So this is the condition where all lobes are involved. Like frontal lobe is giving us the response for what we are seeing. Parietal lobe is seeing where is the target. Occipital is recognizing the color, contrast, clarity of visual acuity as well as the visual field. Cerebellum is helping us for the balancing. Brainstem is for the basic mechanism of our body, and the temporal lobe right is for recognition of recognition, and left is for our letter symbol recognition. So all the lobe is involved. So as we know, in the South India, the most prevalent cause of blindness is cerebral visual impairment that encounters 33% of the cerebral visual impairment. The main reason for getting increase in the CVA is the survival of a premature baby. The premature baby, due to the high facility of the NSE, they are getting survived. But at what condition? That we have to see. We have discussed today in morning also the cause of CVA is HI, the brain lesion. In our case, it was a brain lesion that was causing intracranial pressure rise. It can be infectious changes in the brain injury, neurite hypoglycemia. Here you can see as well in this picture that in HI there is a periventricular leukomalacia changes in there. Around the ventricle there is a changes, and this occipital lobe is getting occipital, and surrounding occipital lobe there is a hyperreflectivity. You can see other brain malformation like alloprosencephaly, senescephaly, lesioncephaly. There is a loss of sulcus and gyrus as well as the hydrocephaly is the main reason for the CVI. And abnormal seizure, abnormal EG, and this is the normal EG. So we are seeing here that baby grabs the world first with their eyes, then with their hand. So this is the prime most sensory system which can lead our full system. Here in this video also. In this video also you can see that the baby is looking at the phone and going and taking the phone. So vision itself is reading all over our body. If the vision is not proper, then there can be a 4 major parts it is going to get impaired. Like is communication and interaction, activity for the daily life, orientation, which child will not able to orient properly, and the last is sustainable vision task. we will not able to sustain or prolong time, not able to read, not able to write properly. So I just want to show this video where it is a cross-sectional image of a control versus CVA. Here we can see that the CVA is having loose connection between the visual pathway as well as overall their brain. So now we got to know like how this CVA is causing low vision. That is 40% of children showing that visual processing is affects the visual acuity. Like just think about the Ratha Yatra over Bhubaneswar. Just think about here. There are lots of information is coming to our eyes, so we will not able to process that information properly. So if you are decreasing the contrast, we are taking more time to process the information because not all the neurons are responding to a visual target, that is impairing the contrast perception. And last is visual field. Most of the patients with periventricular leukomalacia, they used to have a lower visual field impairment. So let's say the patient who came to us with a complaint, my child is not able to play properly. So it is not always it can be due to the visual acuity or contrast sensitivity, can be due to the lower visual field impairment also. So now we want to know why this CVA is happening and how it is impairing our visual function. Now we are going to discuss what we can do about this thing. Like yesterday, Supriya sir had discussed about this 4 model of vision. So I am just going to explain this through my video, where I am using this. Just look at this baby now. The baby is not looking at that toy properly or not to this feeding bottle. So what I am going to give? I am going to give the baby a taste. Now baby is tasting that bottle, getting feed. Now see the baby's behavior change. So this is how your multisensory intervention is working. Now the baby started looking at the target. So whenever I started like giving only a single vision stimulation, the baby is not giving the response. So as soon as the anti-gravity and center in the baby has to understand where is that bottle, identifying this is the bottle, giving the response through his mouth, and the last is the identification, identifying that target properly and tracking the target. So we have done the study on this therapy approach, that is multisensory model in Narendra only, and we are seeing in case of normal as well in case of HI and hypoglycemic cases there is huge improvement for all the 3 groups. So how a low vision device is managing CVI? Low vision device is just segregating the word, reducing the crowding phenomena. Like bar device also doing the same thing. A child with CVI can have a problem in writing. So writing guide can have, a signature guide can have a useful impact on their visual management. So patient with lower visual field impairment can be easily managed with the help of the cane or orientation guide movement, or auditory book can be used if we are giving a sensory substitute cases. So just want to demonstrate the office-based therapy for his case. Here the child have to identify the letter among all the letter or number. The child have to select that letter. Here child is on a balance activities with that child is reading the Marston wall. Now here from all of the targets I will have to identify a particular colored target. Then I have to maintain the balance to the walking rail, because when the patient came to us with a complaint of again the balancing problem, so we are trying to incorporate the balance as well as the vision system, because the vestibular and vision system goes in hand to hand. So here the child is managing different obstacles for the vision purpose, and child is now in a manual balance where child is standing. So see how it's difficult for the child to stand on a balance board, and now the child have to read from the Marsden wall. And child is holding that target in another hand. And now the child is going to complete the task. So it's such a huge and difficult task for this child. So like in general practice, we are in a visual acuity refraction, but we have to see more for giving the visual perception like accommodation, fixation, pursuit circuit, binocular vision, stereopsis. Then only we can achieve the visual perception. I just want to show some more video regarding the vision therapy demonstration where I am just showing the manually facial, different facial expression where the child is looking at the face properly. So here I am using a software where the different colorful ball is going to pop, and child baby old is around 1 year. And the help of her mother, she is looking at the target.
The same Vision Nova.
And trying to fix
Vision Nova,
that target.
created by Manchester in a tab.
And it is not always necessary to have all the equipment. We can simply train with the help of the candle also. We
as a home
can
based
make the light off, and the candle will be the appropriate thing. We can train the child properly. So as we have discussed previously also, the multidisciplinary approach is required to manage the CVI. These are my reference. Thank you.